Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
How Memphis is fighting coronavirus. Tonight on Behind the Headlines. I'm Eric Barnes with the Daily Memphian. Thanks for joining us. I am joined tonight by two doctors from Le Bonheur Children's Hospital, John McCullers, pediatrician-in-chief at Le Bonheur and a senior associate dean at the UT Medical School. Thanks for being here again.
Thanks for having us, Eric.
And Nicholas Highsmith is a doctor specializing in pediatric infectious disease. Thank you for being here.
Thanks.
Along with Bill Dries, reporter with the Daily Memphian. I want to start with you, Dr. McCullers, and we'll try to go through sort of all kinds of things about social distancing, about the state of testing, and about the symptoms and what do you do if you feel like you have symptoms and so on. So we'll try to hit all those things and other issues as we go through this today and try to stay as focused as we can on Memphis and Shelby County, but obviously this is a national and global issue. For right now, the social distancing, and we'll define that, it seems to be the thing that in the last week and a half, you and I ran into each other in a restaurant a week and a half ago and chatted about where is this going to go. I don't think that restaurant, I think they're doing takeout now. I think most restaurants are in the process of closing. People are working from home. Schools, I think every school, public, private, and so on has closed. How far does this go from, hey, let's stay apart and let's not gather in places, to the end of the spectrum where it's shelter in place, don't go out unless it's an emergency or you need to get food? I mean, how far does this go?
So we can think about it in maybe three different phases, and one would be doing just some simple social distancing, protecting those who are immunosuppressed or at risk, and saying, hey, wash your hands and stay a little bit distant from each other, and let's just try to not infect those who are at most risk. We're now in kind of a phase we'd call mitigation, which means we're really doing many things that are designed to stop the spread of disease. So, not gathering in large crowds, working from home when you can, staying away from the grocery store, and practicing that 6-foot social distancing, canceling many events that we might otherwise have done. The third phase, which you refer to as shelter in place, we call suppression, and that is really where you're just trying to do every single measure you can to prevent social contact and to keep the virus from moving at all.
And do you think, from your point of view, we will or we need to end up at suppression, shelter in place, that stage?
It's a very interesting argument as to what is the degree to which suppression is better at this than mitigation, and then what are the costs of suppression. So what are the consequences on the economy and on people's lives of that sort of strategy versus one where maybe it doesn't work as well. We really don't know enough about this to say, I think, what the best thing is, which is why many municipalities are erring on the side of, well, let's do the maximal thing possible for the good of the people.
Dr. Highsmith, bringing you in, your sense in terms of, and we'll come back to some of these social distancings, but I want to get you in on testing. Mm-hmm. And obviously there's a lot of frustration and confusion about testing. The state got 500 tests, which is obviously wildly inadequate. Mm-hmm. What are you experiencing within within Le Bonheur, within the medical system, in terms of your ability to get people tested? Can you get all the people tested that you want to get tested?
So right now the answer is no to that. We cannot get everyone at this time tested that we need to have tested. I think early on when we saw this happening in China and we saw it happening in Europe, we were all, the health departments around the country were looking at ways that they could ramp up their testing abilities. And when we had one or two cases here in our communities across the United States, that was adequate. We could test those individuals and then sort of trace who they had been in contact with, and it wasn't using up a ton of our testing resources at that point. Now that we have ongoing community spread in a lot of the communities in the United States, and we will most certainly have that here in Memphis, I think we definitely need to ramp up our testing capabilities. We've seen some of the commercial labs come online. However, they are severely backlogged right now with all the tests from across the country as well. So I think working on getting a test here in Memphis in-house in some of our facilities here in Memphis is going to be critical going forward.
Let me get Bill. We have obviously a lot more questions on that.
So, Dr. Highsmith, for now, it's not community spread with the cases that we know about. So there is tracing who people have been in contact with, which seems to be a necessary but a tedious process. Do people you contact about okay, tell me everyone that you came into contact with? I would imagine they can't remember that in all cases.
Yeah, so that's true. That's a very tedious process, and I can say that as of this morning here in Shelby County, we have had cases that have all been acquired somewhere other than Shelby County, and they've come in here. So when I say we haven't had community spread, we haven't had community spread here that's been documented.
And I should also note we're taping this Thursday morning, just because it is a fast-moving thing. Go back to you.
Yeah, it's true. I think that will change, and I think there has probably been community spread already in Memphis that we just haven't recognized because we're not doing mass testing waves at this point.
So at that point, when you have community spread, you don't trace. You simply begin to treat and deal with what's going to be a locally spread virus.
So yes, to that question, there has been some. That's sort of what they've started doing in some other parts of the country. They have stopped the contact tracing element, and they have simply ramped up their testing. If you have symptoms, you stay home. Don't go out into public, practice social distancing, and in areas where they have large amounts of tests that they're able to perform, people can go through these testing stations and be tested.
Let me go back to you, Dr. McCullers, and talk real, Mike. What if you have you administered a test yet to someone?
Not during this outbreak.
But if you what is that? Let's take that from there's a box or a swab. Like walk through the minutia of testing.
So testing in this context, you're trying to get a piece of the virus from out of a person's mucous membrane. So what we would do is the person would typically be in a setting where the healthcare worker is protected. So either they're going to the home and they're wearing all of this personal protective equipment, or now we're seeing the drive-bys where people stay in their car and the healthcare workers wearing that personal protective equipment. You then would have a little test tube that would be full of what we call viral transport medium, something the virus stays alive in and is stabilized in. You would take a swab and either swab their throat just like you're used to with the strep test, or you would swab through the nose and hit the back of the throat with the swab. It then goes in the transport media, you swish it around a little bit, break it in half, cap it, you send it to the testing facility where they're then going to run molecular tests which look for the genome of the virus within that sample.
Right now those tests are being sent. There are 2 commercial labs, I think, in Memphis is what's been reported that are doing it. A lot of them are going to Nashville. I mean, in an ideal situation, would they be done, at Methodist, at Le Bonheur, at the hospital itself? Is that where we're trying to get in terms of the speed and of testing?
So there's at least 2 right now commercial labs. There's others that are coming up in the very near future. And to varying degrees, they have to send them to other places in the country because the model is, of course, centralized testing and then back out to the different locales. So some of these are actually going to California to be testing. And you can see with all the travel issues we're having, that creates its own supply chain issues. And it takes 5 or 6 days to get a test back. So ideally, and this is what we're hoping to do at UT within the next 2 weeks, we'd have a test here locally. The test only takes about 4 hours, so if you're running it a couple of times a day, you can get results back in 12 to 24 hours that are actually useful for somebody like Dr. Highsmith to use.
Who, in an ideal world, who would be tested? Because right now it's a pretty high bar, right? I was talking to one medical professional who was saying, look, you got to meet the CDC guidelines of having been in a level 3 country. You have to have been exposed. It's a very high bar. You might have some symptoms, you might have a fever, but you're not going to get tested right now in Memphis by and large. Ideally, who would be tested if the tests were fast and readily available?
So again, it depends a little bit on what the scale is and how many tests you have. Right now, we'd love for doctors who are worried about a patient having coronavirus to be able to test them. So that would be the first line of that.
And not have to sort of, hoard those tests for only the worst, most likely
And you'd like it to be easy to do, you'd like it to be cheap or free to do is another big case. And then secondly, you'd like to be able to test contacts maybe. So somebody's been in contact with somebody, maybe they're a critical healthcare worker, test them, say they don't have the virus, they can go back to work, right?
Before I go to Bill, your sense, and you've I didn't know this, but we were chatting before the show. You've consulted with the CDC. You've trained other people who've been flu specialists. So you've seen this on a national global scale and so on. Your sense of when we will have tests at that scale, the amount of tests that you all as professionals need.
I think within 2 weeks.
Within 2 weeks. Okay, let's go to Bill.
Dr. Highsmith, some people are taking one view that this is the end of the world. Some people are taking the view that what's the big deal? This is just flu like we experience all the time. This is not your normal flu, is it?
No, yeah, that's a true statement. I think that we have seen examples of this in Europe already. We've seen it in the United States already, and some of the experiences some of the communities are having. Simply the amount of healthcare resources that this is requiring is really not something that we see normally with influenza. The severity of the illness in older individuals or those with chronic diseases has put a real strain on the healthcare system in many parts of the country. So I think that we definitely need to take this seriously. I think that young, healthy individuals still need to practice social distancing. We realize that we have severe disease in those individuals as well, but the big thing is transmitting that to someone that is elderly or has an immune compromising condition.
Mm-hmm. Dr. McCullers, what about a vaccine? And does a vaccine, the development of a vaccine suggest that COVID-19 is not going to vanish when this is all over?
So we know the virus isn't going away. It's spread enough around the world that it's going to be here for some time with us. Vaccines are really, really difficult to make. Let me just say that. We've been working on SARS vaccines in the United States and worldwide for 17 years. We don't have a vaccine. We've been working on a vaccine for RSV, which infects babies, for 50 years. We don't have a vaccine. So I think there's hope that we can develop a vaccine to this, but it's not assured. Now, the good thing about the SARS experience is we do have some vaccines that are coming into very early, human trials, so some candidate vaccines. We're able to rapidly adapt those because the viruses are so similar and get coronavirus vaccine trials for the new strain into trials very, very quickly. It still is an 18-month to 2-year process, even if it works, and we're not assured that it's going to work.
So, Dr. Highsmith, your thoughts on a vaccine, and also a bit about hearing the word vaccine and kind of looking at that as, okay, well that's on the way, so we don't have to change behavior. Quite obviously, we are having to change behavior.
Right, yeah, I think that definitely in this point we have to change our behavior. If not, we're going to overwhelm our healthcare system with the illnesses that the elderly and those with chronic medical conditions will have. I think the vaccine is great, and that's something that we can look forward to in the future. But right now we have to deal with what's going on currently. And if we don't practice these measures that the CDC has recommended, we're going to overwhelm our healthcare system.
Do you think this changes our healthcare system?
I would.
Aside from the virus, aside from
Right.
the medicine, is the structure of our healthcare system changing, or should it change as a result of this?
That's an interesting question. I think I would like to see it change as a result of this going forward. I think there definitely can be opportunities for more collaboration around the community amongst all of our healthcare facilities and amongst our health care enterprise as a whole in the city. I think that for a long time we've discussed the healthcare system in the United States, and I think this is the perfect opportunity for that to change going forward. I can't see how it would, but I think that this is the perfect opportunity for that.
Mm-hmm. Dr. McCullers, your thoughts on that?
So I think this is an opportunity for us as a country to kind of revisit how we do healthcare. We have been divesting in in the public health infrastructure and in primary care since the 1940s, when we really rallied around tuberculosis and preventing transmission of that, as well as mosquito-borne illnesses. And particularly in the last 5 to 10 years, we've seen a divestiture and really a lack of respect for and acknowledgement of the public health officials and the experts that really would help us prepare for this sort of thing. So 15 to 20 years ago, I worked with the U.S. Congress and with WHO to work out pandemic preparedness plans, our strategic national stockpile. Since that time, there's just been a degradation of our ability to respond. So I think this is a call to say, after we get through this, we really need to build that back up and make that our primary focus to prevent this sort of thing and prevent just the normal chronic diseases that we see every day that are preventable if we put the resources in up front instead of waiting till they're present and trying to treat the results of them.
I was thinking about this as we were getting ready for the show. It has felt over the last, weeks. It's like a slow motion Katrina, where you kind of see the storm coming. It's like, oh yeah, we get storms all the time. We get flu outbreaks all the time. We always live through those. And then people, as it's getting closer, start saying this is a different kind of storm. And then it hits. And suddenly, and I remember with Katrina, there was this sense that everyone was waiting for the federal government to come in for some days. And then suddenly the locals realized they're not coming. We got to do it ourselves. Is that where we are, where you feel like we are in Memphis, in Shelby County, as a state, that it's really up to Memphis and Shelby County to make the good decisions and get help from the state and federal government where it comes, whereas I think people seem to have expected the federal government was going to lead on this and you all would follow their lead?
So I think there's some elements of that. Certainly, we were supposed to have a strategic national stockpile that had, 95 million N95 masks, for instance, and it did at one time. It now has 12 million because Congress has not appropriated to fill that up. We don't have enough ventilators at the federal level. We've had a very poor federal response the last 3 months. Those are all very, very true. And we're having to do many of those things now locally in terms of setting up our own testing. Okay, so you would have thought the federal government through the health departments would have been able to manage that. They've not been able to manage that. We're having to do it ourselves. At the same time, you don't want every town and municipality making their own rules and doing their own thing, because we are a country and a population that has so much interconnection that if my neighbor is doing something crazy, it's going to impact me. And again, we should be having the federal government help us make those decisions and set some of those rules.
So to that end, let's talk about Le Bonheur for a second. Le Bonheur announced, like maybe it was yesterday, sometime this week, that they're opening, or they visitations for people who are in there for whatever, a broken leg or whatever they've got going on. Only 2 healthy adults and caregivers. Y'all are going to screen them before they come in to make sure their temperature and so on. The volunteer program at Le Bonheur is shut down. Postponing elective surgery. I thought that was interesting. You've heard that nationally. Why is that important, postponing elective surgery? Go ahead.
There's been a bit of debate about postponing elective surgeries and how far you go with that and what really is an elective surgery, right? So if we don't do an elective surgery right now, does that person then develop a bad outcome because of the timing of the surgery is disrupted? Does it become an emergent surgery where it's much more difficult to deal with it? So there's urgent versus non-urgent surgeries. There's unnecessary or nice surgery, like cosmetic surgery, for instance, right, that you maybe don't need to do. But then really, where's that gray area where you need to do it, but do you need to do it now, and do you have worse outcomes if you don't do it now?
And I ask that in part because I know where that bar should be, but back to this notion of a coordinated response. That's Le Bonheur's rules, but I mean, are those the same rules for Methodist, even though y'all are under Methodist? Is that the same for Regional 1? Is that the same for Baptist, and so on? I mean, are different hospitals having different rules, and is that problematic?
I think most of the hospitals are following the idea that you're going to cancel elective surgeries, but they're leaving it up to their experts, which are the surgeons themselves, to say which of those are essential versus non-essential, which do we cancel, which do we not cancel. I think it's pretty much uniform doing that. The one little difference is, hospital-based surgery versus outpatient center. Do we want to keep some of the outpatient center surgeries going so you don't have those get into the hospital later and fill up beds? That's one of the debates we're having right now.
Okay, about 7 minutes left. Go back to Bill.
All right. I want to go back to one of the more basic points about testing. Does everyone need to be tested in this? In other words, should an employer send all of their employees in once there are enough tests or as we get more tests, to have everyone tested to make sure the workforce is safe, because I would imagine that's no guarantee that someone's not going to get this in the future.
Right, true. And I think this is a highly debated issue about who all should be tested. I think you raise a great point with the healthcare workers. One thing we're looking at pretty intensely right now is when we we will be screening at all our Methodist facilities. We'll be screening all the visitors and all the associates that come in. So if we have an associate that is screened positive for an illness, we need to be able to rapidly determine that associate does or does not have COVID-19. So that's going to be one key piece of the testing, and I would say that all associates that have symptoms should be tested. That way we can get them back into the workforce as soon as possible. With regards to our community, I think that is a debated issue. I think that there are some communities that are looking at you have symptoms, stay home unless they're severe, but I think there are other communities that are looking at everyone with symptoms should be tested. That way they can sort of stay away from grandma and grandpa and young children and things like that. And I think that that's probably the way we're headed, is testing the majority of individuals that have symptoms, and I think that's one way to sort of better get the spread under control.
Strategically, should we deal with COVID-19, the novel coronavirus, outside of the hospitals to ensure that the hospitals are not overwhelmed?
I think to the best ability we can, we should try to manage it outside of the hospital. Obviously, if you have severe enough illness that you need to come into the emergency room, you're having trouble breathing, that sort of thing, then obviously that follows a different criteria, and you will have hospital care at that point. But I think for the most part, this should be something that we can manage on the outside of the hospital.
And by outside, is that sort of screening tents and screening locations? I mean, it's what is outside? If it's not inside, what is outside?
And let me clarify that I was thinking of your question as being, should all of these individuals come to the emergency department, that sort of thing. And that is definitely not the model that we are proposing. It would be more of these outpatient screening type centers where we're not directing these people to come to the emergency department for screening.
5 minutes here. Let me walk through just some basic stuff. And people have read this, but I think it's helpful that somebody who's maybe their neighbor and from a local hospital to go through. Symptoms. What are those symptoms that should concern someone or not concern someone?
So one of the important things to realize, the symptoms are fairly distinct. It's fever, cough, and then lower respiratory difficulty, breathing or chest pain, really lower respiratory. This virus doesn't have a lot of the typical runny nose and congestion, things that we see with flu and with some other cold viruses.
All right, as we tape this on March 19th, I think here, what if you feel those symptoms, what should you do?
You should call your physician, or you should call in to somebody that you trust. And if it's mild, you're going to be told stay home, manage yourself at home. Don't come to the doctor's office. Don't go to the ED. If it's serious, you can't breathe, you're having trouble with your breathing, you're worried, then you go to the ED, but call ahead to the ED to tell them you're coming.
That difficulty breathing, just to clarify, is different than a cough. Just for a layperson, right. The difference between a cough, even a bad cough, and the lower respiratory that you're talking about.
Right. So a lot of us are coughing right now because allergy season is coming in, and we got some nasal drip and things like that. So you're going to have a cough. Difficulty breathing is typically chest pain, difficulty getting your air out. Fast breathing, labored breathing is what we're talking about.
If you don't have a doctor that you can call, who do you call?
Well, I would normally say the health department, but the health department is being overwhelmed with calls right now. So this is, again, is one of our gaps in care we have right now, that we have so many uninsured who don't have a physician and don't have somebody they can call.
Are the organizations, and I'm not endorsing here, but like Christ Community, like Church Health Center, some of those, are those places that people without insurance, without a regular doctor should turn to?
They're really stepping up right now. So I do think, what we call our federally qualified health care organizations like Christ Community and others are great places to think about.
Is there a list of those that you could send people to? Do you go to the Shelby County Health Department? They have a list of other alternatives for people to go, again, if they don't have a doctor?
I don't know that there's a comprehensive list. Okay. I have one myself. So I will put it up on our UTHSC coronavirus website. Okay.
And if you were exposed to someone, if it turns out your child, your mother, your girlfriend, your husband, whatever it is, has it, you were exposed, what should you do?
Well, first of all, I wouldn't panic, right? So we know for most people under the age of 60, this is fairly mild disease. If you're over 60, maybe there's a risk for more severe disease. So I would not panic. I would keep doing the same things we're doing with the social distancing and with trying to take care of yourself and wash your hands. And then if you get sick, make sure your healthcare provider knows you were exposed.
If you get it, and people in Memphis have, and more probably than even know have it, right? That's part of the mystery and the murkiness of where we are. It runs its course. I'm acting like I'm a doctor here, but it runs its course. What are the long-term consequences for people? I've had the flu before. I've had the flu multiple times. Is it like that it's a really miserable period of time and then you just go about your life, or is it long-term damage?
Well, we think for most people it would be like the flu and you're going to be okay. There are some cases we're seeing now, including in young, healthy adults who have it, where they're suffering lung damage that probably will be a chronic respiratory issue for the rest of their life. So again, we're not seeing a lot of deaths in young adults, but we are seeing infections, we are seeing severe infections, we are seeing some of this damage.
Okay, just a minute left, Bill.
All right. It's been, nobody alive now in our city has any memory of what firsthand memory of what the yellow fever epidemics were like. From what you've both read about this, is this similar to that?
It's similar in that we're having to do the kind of social distancing. During yellow fever, everybody moved out to the country, for instance, and got out of the downtown. It's a little different in that we do have experts who can talk about it. Back then, nobody knew it was carried by mosquitoes. They worried about the miasma from the sewers and things like that being responsible. And so I think there was a lot more fear of the unknown. We still have that here, but I think we're hopefully able to mitigate that somewhat by going on TV and talking about it with the experts.
Dr. Highsmith, your thoughts on that? I mean, it's the first thing that comes to mind for many Memphians.
No, I think that Dr. McCullers says it spot on. I think that we just need to let our healthcare providers and our professionals in the community sort of guide the response to this, and know that there are people out there who are working on this very hard for the public's behalf.
All right, that is all the time we have this week. Thank you both for being here, particularly in this busy time. We really appreciate it. Thank you for joining us. That's all the time we have this week. Remember, you can get past episodes of the show at WKNO.org. You can also get the podcast of the show on the Daily Memphian site, iTunes, Spotify, or wherever you get your podcasts. See you next week.